My name's Carolyn Walker. I'm a psychoanalytic psychotherapist and also a social worker, and I work as a therapist at the Tavistock and Portman NHS Foundation Trust. A couple of years ago we had the opportunity to develop a new home-based service for patients who weren't able to access existing provision, and my role was to set up and run the care planning service. We were offered some short-term funding to help our GP colleagues develop care plans for a group of patients who were particularly hard to reach, very vulnerable and at risk of avoidable unplanned admission to hospital. We found that there were a number of patients who weren't able to access existing services, including our own, even when it was possible for patients to come to the surgery rather than go to traditional psychiatric and mental health services in the community. These were patients often who had a range of complicated medical conditions, including long-term physical conditions, life-threatening conditions, and often with medically unexplained symptoms. In addition, this was a group of people who often had really complex social difficulties, social isolation, poor housing, poverty, and they tended to fall through the gap of existing services. Separately, we as a trust were part of a new development in the borough of Hackney, which was a pilot programme to develop integrative care across health and social care. Our brief was to offer a psychotherapeutic input alongside our medical and social care colleagues. The team comprised myself for a day and a half a week to set up, establish and manage the service. Then we had a consultant psychiatrist who was also available for a day and a half a week and was a crucial part of the team actually in helping us assess serious psychiatric conditions and manage the associated risk. Then I also had a full-time clinical psychologist who helped with supervising the equivalent of 4 caseworkers who did the majority of the work with our clients. In total, the care planning service operated for 2.5 years. The first few months, when we were urgently trying to help GP colleagues with their care plans, there was just myself and a locum psychiatrist and a locum caseworker. Gradually, once we received funding for our contribution to the integrative care programme that was being established in Hackney, we were able to recruit more staff. And I would say that over the first 9 to 12 months of the programme, we were involved in a process of recruiting the team. We weren't fully operational until about a year in. What was different about the care planning service was that we took as our starting point that these were patients who couldn't reach existing services, and we had to reach out to them. We did this primarily by visiting patients in their homes. I'd say that one of the strengths of the service we developed was the way in which we applied our knowledge and experience of working psychoanalytically and also systemically. We actively encouraged patients to invite significant members of their network, and that might be their carer or a member of their family or even a friend, to contribute to the assessment process. Another way that we worked with the network was to liaise closely with professional colleagues who might have known the patient or their family for some years, possibly were offering an intervention alongside ours or possibly had become stuck. And on occasion, when it was helpful, we'd do joint visits so that we avoided the duplication of separate services, assessing the patient one after another, and patients valued this. Typically, we would receive a referral from a GP or another professional colleague. We'd look at the suitability of the case and we'd allocate it to one of the clinicians in my team. First appointments were always done by 2 members of the team, and we usually offered a home visit to the patient. The assessment process would take place over 1 or 2 or possibly 3 meetings, and then we would offer the patient a short intervention, which might be another 8 appointments, sometimes staggered over a period of several weeks or months, to make the most of the brief interventions that we're able to offer. We had a limited amount of time with patients, and we realised that their needs were complex and often very long-standing. So what we aimed to do was, through the relationships that we worked hard to establish, was to try and get alongside the patient and get a clearer understanding of their difficulties in the context of not just their physical health problems, but their social and emotional lives. And also, working from a psychoanalytic perspective, we would take into account their earlier history and relationship difficulties, which might really be getting in the way of their ability to make use of the services that were available to them. The name that we came up with for the service, care planning, didn't really capture the essence of what we were doing. Some of these patients did have care plans that weren't working. Sometimes the outcome of a successful intervention by the care planning team, however, was that the patient and the caseworker together could draw up a new care plan, one that they felt more accurately met the essence of their needs, both social, medical and emotional. And often what caseworkers was able to do was to signpost the services that the patient was most able to make use of. I think what patients and GPs told us they really valued about the service were a couple of things. One was our tenacity in engaging with patients. We were quite persistent. Sometimes we had to knock on patients' doors more than once before they'd be prepared to answer the door. And they told us that they really appreciated that we didn't send them a discharge letter if they missed their first or second appointment, as is often the case, sadly, nowadays. GPs and patients, I think, also appreciated the time we took to get to know about their lives, including, as I've said, sometimes to meet with family members, to hear about their wider social network, to try and get alongside them to understand their experiences of their difficulties and of working with services. I'd say there were perhaps 3 key learning points from our experience of the care planning service. Firstly, that we uncovered an area of unmet need, and that actually there are a group of patients that, now the service is folded, aren't being reached by mainstream services, and their complex needs will increase, their difficulties, one fears, will not be addressed, and their need for costly services will only increase. In addition, I'd say, looking back, that something that would have been helpful from the start would be for us to have been as clear as we could be about an agreed set of outcomes by which to gauge the success of the service and increase our chances of it being recommissioned. There were a lot of difficulties with that along the way. The third learning point, I'd say, was the difficulty in running a service like care planning in such a short space of time. We had to design the service, recruit the staff, and then retain good quality staff working under very insecure contracts. We also had to find a way to promote the service to our GP colleagues in the community, and we have had feedback that actually GPs find it very difficult to keep up with the number of new short-term services that may be established only to fold after a couple of years, as ours was, due to lack of funding. So although the care planning service has folded, I do think that it had raised an awareness in people's minds of the need for a new kind of service that actually isn't provided for in mainstream services, which is a psychologically minded, home visiting based service for patients, which takes into account their families and their wider social context, as well as their immediate presenting medical concerns.